Instagram. I am very happy to connect with people, answer questions. I will have a link to a couple things at the very end, but we also have a podcast that answers a lot of questions with me and my husband. Feel free. I'm a very approachable, easy to connect with person, and I love connecting with you guys, pre-meds, med students, everyone. All right, so let's get started. So what is pediatric cardiology? So the basics is pediatrician who specializes in the care of hearts ranging from fetuses to young adults. So not all pediatric cardiologists go down to the fetus level. I do, and I'll explain that in a little bit. But we basically are the masters of congenital heart disease, and congenital heart disease basically just means any structural defect of a heart. And in pediatrics, I often get a lot of people who ask questions about the difference between pediatric cardiologists and adult cardiologists. Well, we are quite different. The reason for that is that the kind of disease or the kind of things that we are looking at are very different from what cardiologists in the adult realm are taking care of. So by far and large in the adult world, it is much more about coronary artery disease, disease of lifestyle that then results in lots of pathology from there. In pediatric cardiology, we don't see adult onset congenital coronary artery disease. A facet of my practice focuses a little bit on that, but it's more in the prevention realm. But our bread and butter is really congenital heart defects, and congenital heart defects make up about, depending on the source, between 0.5 to 1% of all births. So it is one of the largest fields with congenital defects. And so those defects can range from very small to very severe defects. And we are the experts in those defects. So I often like to say that we are a very specialized field that not a lot of people understand and are very scared of. with due cause, because pediatric cardiology, because structural heart defects in children is very hard to understand, and you have to have a very good baseline knowledge of what normal structural anatomy is before you start to understand what can go wrong with it. If you talk to adult cardiologists, they'll probably tell you that they are very scared of pediatric cardiology issues as well in congenital heart disease, and it's because it definitely takes a lot of knowledge to know what we do. I personally think it's the coolest specialty ever. I'm a huge advocate for the field. It's a very young field, I would say. Pediatric cardiology used to be really where not as subspecialized as it currently is today. We have been able to improve intensivist care, improve our surgical care, improve our interventional care, to where a lot of heart defects that previously would have really bad outcomes or result in a very limited amount of lifespan in a lot of patients has come that the lifespan of our patients has gone up dramatically with a lot of new technology, a lot of better care, a more understanding of optimal timing of intervention and how to treat certain things. We've come a long way in the field, and we continue to advance in the field. So it's a really great specialty. And so let's go to the next one. So how do you become a pediatric cardiologist? Well, obviously you guys sort of know this path. A lot of you guys are pre-meds or med students. So undergraduate degree, however long it takes. For me, I went to Arizona State University. I'm originally born and raised in Arizona, and I went there and I studied for 4.5 years and got my degree in biochemistry. a little side note, probably one of my biggest regrets. And you may ask why, and it's because honestly, I didn't really like biochemistry. I just thought it was something I was supposed to do as a pre-med, because you had to be sciencey and all that stuff. I kind of wish I did something more fun. These days, I kind of wish I had majored in nutrition, because I really think that would have been helpful to have that base as a physician, as I really do believe that every single practicing physician should be looking at prevention, and a lot of that is through lifestyle. But anyway, side note. Then the next one obviously is medical school, allopathic or DO med schools, either one. They're both produce fantastic physicians, and I want to be very clear about that. There's been a lot of talk about DO stuff. MDs, DOs, same. That is my bottom line, sticking to it. And so medical school, 4 years. After that, you match into a pediatric residency. So by far and away, the way into pediatric cardiology is through a general pediatric residency that you match into, which is 3 years. There are some programs, and I'm not sure of the exact number or details of this, but there are probably some programs. I know Stanford is specific to this, is where I trained for my residency and fellowship, where you can actually match into pediatric cardiology from medical school. It shortens the time a little bit that you would have to do it, and you have an automatic entry into fellowship, but it's, like I said, it's very, very few, and it's for students or med students who know from the get-go that they want to do pediatric cardiology. Obviously I love the field, and I have mixed feelings about that, because I do think it's really important to get the breadth and understanding of what you really like before completely setting your course on something. But hey, if you see me today and you decide I want to be a pediatric cardiologist, and that's your thing, and you decide that and you want to try for one of those programs, that's great. But the normal way of doing it, or the majority of the way people do it, is a pediatric cardiology pediatrics residency, which is 3 years. And then you have to match again into a pediatric cardiology fellowship, which is an additional 3 years. That is where I stopped. And so I practice what I call general pediatric cardiology. You can further subspecialize in pediatric cardiology, doing 1 to 2 to 3 year post-fellowship trainings. The big types are you can do an extra year in interventional. So that is pediatric cardiac intervention, pediatric interventional cardiology. And those are the people who do the caths. So caths are where you access the heart through growing vessels. And a lot of people think of it from an adult side, where people go in and put in stents into the coronary arteries when people have a heart attack or have plaques build up. In pediatric cardiology, it's a little different. A lot of it is hemodynamics, just checking out pressures inside of the heart. They can also do interventions where they close up holes, and they stent open usually vessels in the lungs, put in new valves. It's actually a very cool field. It's something I thought I was going to do. And then life happened, and I decided I wanted something different. There's also a heart failure transplant. So that's an additional year, and they're specialists of all kids who have failing hearts, who have structural heart defect or acquired heart disease or anything. And they would do a lot with more advanced life support. So putting in ventricular assist devices. They specialize in patients who get heart transplants, both before and afterwards. And that's a really interesting and dynamically growing field. There's also something called electrophysiology. Those pediatric cardiologists are the masters of arrhythmias and heart rhythm, and they do procedures where they can ablate pathways or do certain things to take care of any heart rhythm abnormality. There's also intensive care. So there's a couple ways to become a pediatric cardiac intensivist. That is either through actually an intensive care tract or a pediatric cardiology tract, where you can do several different ways to get there. That's also a really great field. And then there's other smaller ones that are coming up. Well, actually, there's another one that's imaging. So you can do additional echocardiography, where you do advanced imaging with MRIs, and that's a little bit extra. And then there's smaller fields like pulmonary hypertension. And there's a new new field of growing prevention. So lots and lots. So this, I'm talking, but I just wanted to kind of get you the fact that most people don't realize that this field is as expansive as it is. We see a lot of things, we take care of a lot of patients, and you can have a lot of different roads as the pediatric cardiologist. I think that sometimes it gets lost, and a lot of people think that that's only available in adult cardiology, and it's not. The two fields are very different, and like I mentioned, the pathology that we take care of, but we have the same kind of specialists who just do different things in their specialties. So let's see, who am I? So like I just mentioned, I go by Dr. Renee Rodriguez. Married name is Renee Paro. I went to medical school. So I went to undergrad, like I mentioned, at Arizona State University, graduated in 4.5 years from there, and then went on to attend the University of Chicago Pritzker School of Medicine, which was a phenomenally fantastic 4 years there. That is where I met my husband, John. We were in the same medical school class, and we started dating our 2nd year, and we couples matched our 4th year. Happy to chat with anybody about couples matching in the future if you ever have that on your plate. And we couples matched at Stanford. So I matched into pediatrics. He matched into general surgery, and then eventually actually transitioned into the plastic surgery program at Stanford. And the rest is history. So I did my residency and my fellowship both at Stanford Children's Hospital. I was a chief fellow from July 2015 to July 2016, where I sort of led the fellowship groups, got to actually be very actively involved in selecting the future pediatric cardiology fellows that were coming in during my last year, and still to this day do a lot of mentorship with a lot of the fellows that I interacted with from that time. So I graduated from my fellowship in 2016, and then I took a job in the Bay Area along with my husband at our organization is called the Palo Alto Medical Foundation, or it's a Sutter, under the Sutter organization in Dublin, California, which is located in the Bay Area. So the way we kind of describe the Northern California Bay Area region is we kind of talk about it in retrospect to the San Francisco Bay. So I'm on the east side of the Bay Area, kind of southeast of Oakland. So, and then just something else to add about me is I actually I'm part-time. So a lot of people ask this question, can you be part-time? And I always answer everyone when you ask me, can you be anything? You can be anything. One of the amazing things about being a physician is that your abilities are not limited. You have a high level of training that makes you able to take on multiple different roles in multiple different areas. There are doctors who do everything across the board. And so if I can, I'm going to teach you a couple little things about the heart. You guys are going to learn this eventually. You'll just maybe hear it from me in a different way. But if there's one thing I can leave for you, one kind of feeling I could leave for you is to recognize that you are very powerful, and you, as a physician, you are going to hold a lot of power. And so taking that on and recognizing that you can make your life what you want it to be, even if it seems like you have to follow a strict regimented path. You do, right? To get to medical school and to training, you have to do all of these things and you have to follow the road. But what I hope it never takes away from you is that you don't have to keep following a path that isn't right for you. And so a really big thing for me, like I mentioned earlier, is I thought I was going to be much more of an intense specialty doing pediatric interventional cardiology. I had my son in between, my firstborn son, in between residency and fellowship, and it completely changed me and made me reset what priorities I wanted. And from becoming a mother and being married to a surgeon, I recognized that I loved being a doctor and I would always want to be able to do that. But I recognized that if I practiced full time, I would burn out. That I really wanted more things. I wanted the ability to be different and multidimensional in my life, and being a full-time physician would not have allowed for that, for me to also be the kind of mother, wife, person to myself that I am, advocate, all the things I am. So I made a conscious decision when I graduated from fellowship that I did not want to work full-time, and I was able to actualize that vision by networking, by believing in myself, to talking to people, by advocating for myself. And so now I work 2.5 days a week, and the other 2.5 days a week, I guess. Yeah, the other 2.5 days a week, I get to do all the other things that I love to do. So my practice, so like I mentioned, I'm a general pediatric cardiologist. So what does that inquire? So I definitely have children who have congenital heart disease, so structural heart defects that I take care of. I do not do surgery. So that's or procedure, or sort of invasive procedures. So that's something I get asked a lot. People who do surgery are pediatric cardiothoracic surgeons, and they are a very different breed. They cannot be 2.5 days a week part-time like me, but they are incredibly skilled surgeons, and it takes a long path to get there, but we are forever indebted to our pediatric cardiothoracic surgeons. So I don't do surgeries. The things I do as a general pediatric cardiologist that I have in my clinic is I read ultrasounds. So those are called echocardiography. That's kind of one of my big things that I do. I also perform and read EKG, so electrocardiograms. I place rhythm monitors, so something like called a Zeo patch or Holter monitors if I'm screening for some sort of arrhythmia or looking for something different. Those are the major procedures that I do. Anything else where I'm doing a treadmill test, or I'm sending out for MRIs, or I'm doing an invasive sort of an interventional cath, those all go out and I refer them to local children's hospitals. And I'm lucky enough to practice in the Bay Area, where we have phenomenal cardiac centers. Typically, I will either send to Stanford or UCSF, mostly Stanford because that's where I trained. And so any problems or any things that I can't take care of myself or that need additional workup, I will send off to the local children's hospital for those things to be done. I think it's really important to recognize that in medicine, we are a team. We're a team all throughout. And, in my practice, I am in my own small location by myself, but I'm never really by myself. And I think it's really important to recognize that people are always a phone call or text message away. And this is why being a team player all throughout your training, gaining mentors, gaining people who will always be there for you is so important, because you want to be able to have a network of people to reach out to. So I am a specialist of congenital heart disease. I also do a lot of screening for familial disease. So there's a lot of different conditions that can present that are genetically predisposed to putting someone at risk for a cardiomyopathy or some sort of disease of the heart muscle tissue. Things that you may have heard of, like hypertrophic cardiomyopathy or dilated cardiomyopathy, those type of things, where I will screen kids of parents who have a diagnosis and sometimes send genetic testing and do all that kind of stuff. And then I see a lot of patients who just come to me for specific symptoms they have or a finding on physical exam. That's probably one of my bigger things. So you may have heard of patients have heart murmurs, or if they've had chest pain, or they've passed out, or have had palpitations. All of those things, I will see those patients in clinic. I will say that by and large, the majority of the time that I have patients who present with those things, it is very rarely heart related. Kids tend to have a really strong, healthy hearts that are not impacted by a lifetime of not taking care of it, which is different in adult cardiology. But as in everything in medicine, I have to see them and evaluate them and take all into detailed history, do an examination, all of those things to decide whether or not those symptoms are actually cardiac related or not related to the heart. I also, as a part of my practice, have preventative cardiology as a pretty big part. So not all pediatric cardiologists do that, but I have a very large passion for prevention. As I say in my clinic all the time, pediatric cardiac issues like true congenital heart disease is a very, very small subset of the population. And they need to have great care, which I want to provide. But in my mind, I want to have a bigger effect on medicine in general. And knowing that cardiac disease is in adulthood is much different, affects a lot of people, so much so that it is the leading cause of death in both men and women. Oftentimes, women don't put as much thought into this, but it's the leading cause of death in men and women in our country. And so we know that this is not something that just happens overnight in adulthood. This is years and years and years of lifestyle, of things that could be prevented if people started to take care of themselves earlier. So I specialize in preventative cardiology, really to start driving that message in to kids at an early stage. And so how kids get sent to me is typically when they're overweight or obese, have screened for high cholesterol, prediabetes, have high blood pressure. All of these ways are avenues to get into my preventative clinic. And that is a very different clinic than my pediatric cardiology clinic. I don't do ultrasounds. I don't do EKGs. That is all counseling. Sometimes a very small subset of patients have familial hypocholesterolemia, or something where they have a genetic defect which predisposes them to very, very high cholesterol levels. Again, that is really rare. There is some genetic components to people who have high cholesterol, and for those patients who have super high cholesterol, I will tend to usually have them more taken care of in an academic center, because that's usually more people who are a little more skilled in that. But for the majority of the patients I see, it's really much a little bit genetics and a lot bit lifestyle. And so I take that time where I actually spend 60 minutes to 70, 60 to 80 minutes in these appointments going through everything the kid's eating during the day, everything how they're moving their body, how their stress is, how their sleep is. And I'm able to really talk to the kids and the parents about how to take care of their hearts in the long term. It is a very long and usually by the end, the kid's ready to hear me stop talking, but these are very fulfilling. This is a very fulfilling part of my practice, because I'm able to see when kids get motivated to start making some changes and see them drop their weight and see them drop their cholesterol and their diabetes, and really see them change their life in that moment. Because a lot of times these early wins can lead to understanding that putting in they have a lot more control over their health than they recognize. And so that is a part of my clinic that I absolutely love. And then another part of my clinic is fetal echocardiography. So I mentioned fetuses earlier. So I am able to interact with pregnant patients. So I get patients who are sent to me who need an additional fetal heart ultrasound in addition to their normal anatomic scan. So when patients are pregnant, they go in, they all have a routine 20-week ultrasound where everything from the head down to the toes is looked at, measured to see if everything is normal. Sometimes I'll get patients who come to me because there's something that was seen on the heart ultrasound, a defect or something worrisome, and then they're referred to me, and then I can do a targeted fetal echocardiogram for that. A lot of patients I get as screening, so there are certain conditions that we do fetal echocardiograms on all pregnant patients for. Right now it's IVF, in vitro fertilization. There's a little bit of a discussion whether or not that's going to be in the future. But that right now I see IVF patients. I see patients who have high blood sugars or diabetes, specifically the ones who have uncontrolled diabetes or early onset gestational diabetes, usually requiring insulin in the beginning of pregnancy. So if you have blood sugar issues early in pregnancy, we know that there is an increased risk of congenital heart defects due to that. So we see all of those patients. We also see patients who have things like lupus or Sjogren's disease because they have a predisposition in their child to heart block. So I do fetal echo, and I gotta say, it's probably one of my favorite parts of my practice. You guys heard me saying my favorite parts, probably like she likes all of her practice. I do. I love all my practice for different reasons. A little tidbit about me is that I actually considered heavily going into OB and recognized that I didn't really wasn't really as invested in the care that sounds really bad. I love women, but my passion was not women's health. My passion was childhood health. And so, so I decided against it, but I have always loved pregnancy. And so this is my little way back into being able to be involved in obstetrics, which has been very fun for me. Okay, so let's chat a little bit about something. I thought that this is a really funny, I don't know if you guys look at the awkward Yeti, but I thought that this is a really funny cartoon. The heart clearly always makes me laugh because he's the heart and he's the coolest. So I often ask, I put this up as well because I often feel like this is how parents come into my office, irregardless of whatever venue that they have to come in. When they are seeing me, I feel like they are kind of holding their breath for something really bad. And I am so happy that the majority of the time I get to tell them that everything is okay. And when I don't, it's actually also very fulfilling because I get to walk them through a challenging diagnosis that I have to deliver. So anyway, another little point is if you guys haven't discovered the awkward Yeti, you should. It's a really funny medical little thing. So so I don't have necessarily a patient, I don't have necessarily like a patient case to share with you guys. I think it's a little more beneficial for me to spend some time talking about heart anatomy. And for some of you, this may be like old news, but for many of you, it won't be. And I think that a little thing is really understanding the heart is at its baseline, especially for pediatric cardiology, is extraordinarily important. Understanding how the heart works and how it's structured normally. If you don't have that grasp, then as a pediatric cardiologist, you're never going to be able to then build on top of that base to understand heart disease, congenital heart disease, which I will tell you, every single part of this can be put in a different place. It's crazy. Like things can come in or go out in completely different ways. And so you have to have a baseline understanding of the heart normally before you can ever think to understand the pathology behind it. So I'm going to tell you about how the way I describe this to my patients in my clinic about the heart. And I like to describe it as the heart as a house. Okay, so your heart house has two upstairs rooms, your atria. So that's the right atrium and the left atrium. And these are the blood collecting rooms. So these are the rooms where blood is coming in from the body or in from the lungs, in from the body on the right side and from the lungs on the left side, and collects there. Those are collecting chambers. And then there are two downstairs rooms, or the ventricles, and these are the blood pumping rooms. Okay, so these are where the blood comes in from the collecting chambers and then squeezes out either to, on the right side, the lungs, on the left side, the rest of the body. So upstairs, downstairs, and in between your upstairs and your downstairs, there's a set of doors. And so those are your atrioventricular valves. Easy to remember, right? Atrioventricular valves. So that is on your right side of your heart, your tricuspid valve. On your left side of your heart, your mitral valve. And so these are the doors between the inside of the heart, okay? The doors between the inside of the two rooms of the heart on either side. And then there are doors to the outside of the heart, and those are the semilunar valves. And that is the pulmonary valve, which takes blood from the right ventricle to the pulmonary arteries and to the lungs. And then you have your aortic valve, which is the valve leading from the left ventricle out to your aorta to the rest side of your body. So these doors or valves connect from the heart to the outside world. There are also two walls in the heart. And one is at the top. You can't really see it in this picture, but it's called the atrial septum. So that's this. So septum is basically wall. And so that's between the right atrium and the left atrium. And then there is the ventricular septum, which is the wall between the right ventricle and the left ventricle. So I like to think of things in different ways. I will be very honest with you. I've had early med students who've messaged me and are just like, I really want to like cardiology, but I can't stand it the way I'm learning it. It seems so complex and I just don't understand. Do you know that as a second-year medical student, I said, I will never be a cardiologist. Mark my words, you can even ask John this question. because he was sitting next to me all the time. I hated cardiology when I did it in anatomy. I didn't like it when I did it in pathophysiology. I was not a fan. I thought it was just too complicated and I couldn't understand. But the second I started really taking care of patients at the bedside and understanding it, it completely changed in my mind. And so don't ever think that, like, especially when you're in med school, that like how you feel about something in the first couple of years dictates for sure how you're going to feel about it, because clinically taking care of patients can change your mind about concepts. And I am living proof of it. I never thought I would be a cardiologist, and now all I can do is sing the praises of cardiology. All right, so I'm going to talk a little bit about auscultation, because you guys, like, everything's all fancy now. Like, we have MRIs and echoes and all those, and those are all wonderful things. But in many fields, the physical exam in some ways becomes less relevant. In pediatric cardiology, it is extraordinarily relevant. And that is because auscultation is one of the biggest tools of a pediatric cardiologist. So actually, a lot of people, when we went into this pandemic, a lot of specialists, a lot of doctors were able to really transition a lot to telehealth for certain things. And really and truly, I wasn't. If I was going to need to see a patient, they needed to come into the office to be able to be seen. And the majority of that is because I needed to be able to listen and feel and do an entire cardiac exam on a patient in order to provide appropriate care. So auscultation is important. So your stethoscope is a terrible picture. So there's two parts to it. You have your bell and you have your diaphragm. And when we're listening to a heart, there's multiple locations you can listen, but the major locations you want to listen to when you're listening to somebody on a cardiac exam is the 4 locations sort of surrounding the sternum, and really just the locations of the heart. So you can see kind of like the heart shadowing here. So there is little mnemonics you'll start to learn about where you're listening to. So the right upper sternal border is going to be more in the aortic valve location. When they're talking about aortic pulmonary, they're talking mostly about valves. So you're going to be in the aortic valve position, sort of on the right upper sternal border there. If you're really wanting to get a good listen to the aortic valve, that's where you want to target to listen first. Then you have the left upper sternal border is your pulmonic valve, so the one leading to the lungs. Left lower sternal border is a tricuspid valve, and the apex down here is your mitral valve. Other places that are really important to listen to, especially in kids, is listening to the back. So there are some defects that will radiate to both the back. Other places are the neck, so you can hear certain heart sounds up in the neck, and then right up here as well in the upper sort of the clavicular border, we listen around here a lot too. So heart sounds. So just like I mentioned before, in order to know what's normal, or in order to know what's abnormal, you first have to be able to know what is normal. And I apologize, guys. I was a little bit last minute procrastination. I have some heart sounds for some murmurs, which I'm going to put on in a second, but I don't have like the regular heart sounds. So you're just going to have to hear me saying it out loud. So the heart sounds, when we're listening to heart sounds, what are you even putting your stethoscope down to hear? So the most important thing, so you're hearing the heart sounds, is really hearing the lub-dub, lub-dub, lub-dub. And so what is the lub-dub sound in general? Well, they're denoted as the S1 and S2. S1 is a lub, S2 is a dub. Okay, so each of those heart sounds are the closure of, I probably didn't write this right. So they denote closing of two sets of valves, a set of valves, not two sets of valves, closing of a set of valves. So S1 lub is the closure of the tricuspid and the mitral valve. So the inside of the house valves, okay, the collecting to the ventricle. So that is the lub, is the tricuspid and mitral valves closing. The dub is the semilunar valves closing. So your aortic and your pulmonary valves, okay? So if you are listening to a heart, a normal heart sound, all you're hearing is lub-dub, lub-dub, lub-dub. Anything you hear in addition to the lub-dub is an additional heart sound. Does not automatically mean it's abnormal, but it's an additional heart sound. And so when we're listening for additional heart sounds, you are listening for murmurs, and murmurs are basically more sort of like whooshing sounds that happen in between S1 and S2, or in between S2 and S1 in the next cardiac cycle. So a little thing to know, a little pearl is so the first between S1 and S2 is actually a systolic vowel, a systolic murmur. Between S2 and S1, an additional cardiac cycle is a diastolic murmur. Diastolic murmurs are always pathologic, always, okay? You never have a normal diastolic murmur. In opposite, the majority of systolic murmurs are actually normal, but they can be abnormal as well. Gallops are just additional sort of kind of clicky sounds that happen in the heart. There's something called an S3 gallop and an S4 gallop, and they can be normal. S3 gallops, well, we're not going to go into that one. They basically can be normal or abnormal. Rubs are also abnormal. A rub sound is kind of like it sounds. It actually is very, in the book, it's in books, things are really what they're described in textbooks, but rubs are exactly what they're described in textbooks. It sounds like tires rubbing. And a lot of this ends up having to do with pericardial disease, or the sac around the heart. When there's something going on there, that's when you tend to get rubs. And then clicks are really additional sounds to the S1, S2, and clicks tend to have to do with some sort of valve itself. Defect is kind of like, so it's kind of like a little additional sound. And I think I have one where you could actually hear a click. So let's get to something fun. Okay, so I talked a little bit more about murmurs, because murmurs are really important. I see murmurs all the time in my clinic. So we grade murmurs in several different ways. Our way we describe murmurs are several different ways, but we grade all of them in a very sort of systematic way. So grade 1 is barely audible. And grade 2 is audible but soft in comparison to S1 and S2. A grade 3 is moderately loud, but there's no thrill. So what a thrill is, and so I talked about auscultation, but palpitation and inspection are also extremely important in the cardiac exam. So a thrill is if you put your hand on the chest of a patient, you can actually feel a rumbling that goes across your fingertips, or your sort of side of your base of your palm. So a grade 3 is loud, but there's no thrill. Grade 4 is loud with a thrill, where you can actually feel that thrill across your fingers or your hand. Grade 5 is audible with the scope barely off the chest. So you kind of take your stethoscope and you turn it on its side a little bit, and then you can still hear the murmur with your stethoscope tilted. And then grade 6 is you take your stethoscope fully off the chest and keep it there, just above it, and you can still hear the murmur. Let's see. So I'm going to skip this because this is a talk I adapted for nurse practitioners and did a while back, and this is a little bit over the top. So we'll do that. We can do that at once. So let's chat a little bit about, let's listen to some murmurs. Okay. And I should have put some actual, some pictures on this to tell you what this. So what a patent ductus arteriosus. So let's go back really quickly up to this, oops, too far. This picture. So a ductus arteriosus is a fetal remnant that exists from, so all fetuses have a ductus arteriosus, okay? And the ductus arteriosus is a connection from the aorta to the pulmonary artery. The reason why this exists is in fetal life, those patients, like I explain to mom all the time, they need a ductus arteriosus. If you don't have a ductus arteriosus, a connection between these two, then the fetus is incompatible with life. The reason why is that babies don't need their lungs for oxygenation. Babies get their oxygen, or fetuses get their oxygen through a placenta, the placental flow. And so the in the fetus, this blood comes in from the on the right atrium down to the right ventricle, and then when it's traveling through here, instead of going to the lungs, which are super fluid filled and don't have any ability to oxygenate, it goes through the ductus arteriosus and then out to the body. There's also a large connection at the top of the heart as well in a fetal life. So a patent ductus, so the ductus arteriosus is supposed to close in the first 48 hours of life. And there are some patients, sometimes it happens a little bit more in preemie patients. There are some patients where their ductus arteriosus does not close and can present a problem, needs to happen. So listen to this sound. Do you hear it? Dub, 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 dub. So, but you hear that extra whoosh. So that is a 2 to 5 murmur. It's continuous. So we talked about systolic murmurs and diastolic murmurs. This murmur for this defect sounds like just a continuous flow. And that's because there's pretty much flow that's going through that ductus arteriosus the entire time. There's another one that's called, so an atrial septal defect. We just talked about the extra ductus arteriosus. We talked about what the atrial septum is a wall, right? So it's a hole in the top of the heart. You don't actually hear a murmur from the hole in the top of the heart the reason why there's a murmur that's present when there's a large hole there is that there is redundant blood flow across the top of the heart that then goes through the pulmonary valve. So the murmur you're hearing sounds like a pulmonary valve murmur, but it's actually just additional blood flow that goes across the pulmonary valve. We talked about the pulmonary position where you can hear it. So like I said here, with an ASD, you don't always hear a murmur. And it can tend to take some time. It's actually one of the most missed defects until later on in life, because a lot of times it just sounds like an innocent murmur and pediatricians don't necessarily refer, and then it can picked up later. What is different is the S2, which we talked about, right? S2 is the aortic and semilunar valve closure. So the S2 is actually not a single closure. It changes with breathing. So we call it a physiologically split S2. So the heart changes its physiology in respect to the lungs taking breaths. And so so you can hear sort of at some certain points of the cycle, you just hear one closure, and other points of the cycle you hear in the dub part, okay? And so an ASD will actually have a fixed split of the S2. So you'll never hear it coming together like this. It'll always be. So that is a little bit more, and I talked to this about pediatricians or other people, primary care physicians, that is something you really want to listen to, the S2. If you're hearing an innocent murmur and you also hear a fixed split S2, it doesn't ever come together, then you need to think atrial septal defect. And so let's hear this one. You can hear it. Can you guys hear that? Okay, so that's an ASD. That's an ASD. A VSD is a hole in the bottom of the heart. So like I mentioned before, in fetal life, the atrial septum does have an opening. It's actually called the foramen ovale. And then if it's still open when after birth, going into adult life, then it's called a patent foramen ovale, or PFO. Some of you may have heard of that. So, but a hole in the bottom part of the heart should never exist. If there is a hole in the bottom of the heart, it is a congenital heart defect, no matter what. So this one, let's take a listen to this one. So this is interesting. So one of these, you can almost barely even hear S2. Like you hear the beginning of it, and then you hear the, and it almost completely makes S2 go away. You can't even really hear it. So that one is a really classic. VSD murmurs, when you've been doing them over time, you start to hear them and really know what they are very easily. Let's see what else I have. Oh, okay, this one's good. So this is aortic valve stenosis. So this one, something we see a lot more in adults, but we can see it in kids. The reason why I like this one is because there's actually a click. So we talked about a little bit of a click. So the aortic stenosis, what that is the aortic valve gets calcified in adulthood. It can also just be small or not formed correctly in kids. And when you hear it in the aortic valve position, which is the left upper sternal border, you can not only hear a murmur, because if the valve doesn't open well, then the blood flow going across it, you just hear that sound. But it also you can hear a little click, which means that you hear the valve kind of trying to open a little bit. So let's see if you guys can listen to that one. So this is just the click with no murmur. Let's see if this one has a murmur. So that's a murmur. All right. So, okay. So that was a little fast paced, and I wanted to get you guys with some 10 minutes left of questions. Please, dear God, if you don't understand this, do not expect yourself to understand this. I talk about it, think about it, right, guys? I'm 38, okay? I started medical school, 10 years ago. It was my 10-year med school. I have been doing this for like 10 years because I knew that when I once I got into residency, pretty early on, I wanted to do fellowship. So I have been taking my time learning this stuff for almost a decade. So this stuff is going to come to you with time. I think it's really important to take away little points, even if you got some small thing, and I hope maybe the heart house thing helped a little bit of you, then that's a win, okay? So that's my presentation.
Thank you so much, Dr. Rodriguez. There were a lot of questions in the chat.
Okay.
We can go ahead and read some off to you if you would like.
Yeah, that'd be great.
Okay, so someone asked, what happens if you misdiagnose something or if you don't know something? How do you handle that?
You feel really bad. Feel really, really bad about it. And I think it's all about connecting with patients and having them understand that we are working with a specific framework and we're all doing our best, but sometimes we miss things. And sometimes things look to be a certain way and they are not. So I think I try to be very open with patients about how much gray there is in medicine. And the reason why I do love pediatric cardiology is that you do have a question and a lot of times you can answer it, right? So I can do studies or I can do certain things to answer a specific question. But I always leave patients knowing, even if something looks conclusive, that things change in medicine, that we always are learning more and there may be more things. And so I really take the time to talk to patients about the limitations of studies and the limitations of our knowledge at the current moment, and then spend additional time, especially with patients who come in for like chest pain. Clearly doesn't seem cardiac, but I counsel families like, if it changes in the way it is, or something different happens, or additional family history comes into play, then I need to know that, because then that changes the clinical outcome. So I think that the more transparent we can be with our patients, and the more, humbling and show humility, and having them recognize that we're human beings and we're going to make mistakes. It's not intentional, but it can happen, and it sucks. It feels really, really bad. But you have to have grace with yourself and compassion with yourself just as much.
Another question we had was, do the sounds that you showed us, do they become more dangerous if you don't catch these early?
So I would say that it just depends on the defect and what it is. Pediatric cardiology has come a long way in that we are able to pretty much prenatally diagnose the majority of significant disease in children. So the fetal echo has come an incredibly long way. And so we are able to really pick things up, even tiny things up, very early. So we pretty much know what kids have. The things that can go sometimes missed, like I mentioned, the ASDs, those are defects that are not going to pose a very big risk, even if it's a large one, to kids. It's really more in adulthood. So picking those up like at 4 or 5 or 6 or 7 or 8, which sometimes we do, doesn't have a hugely bad effect on kids, and can pretty much reverse itself pretty easily once we take care of it. So we have a lot, and there are other things, there are inherited conditions, but again, we're screening a lot more kids now. We know a lot more in the adult world of certain conditions that make a predisposition to an acquired defect more. So we're seeing more kids then. So, are there things that fall through the cracks? Yes, of course. And kids can present later. I had a patient who presented at 3 with a severe congenital heart defect, whose parents were both, college educated, fully employed, had been seeing all kinds of specialists really well, but he just didn't have anything that was super worrisome. And then found he had high blood pressure and ended up having a really significant disease that I had to, in a week, turn the parents that they couldn't go on their Alaska trip, and he needed open heart surgery in a week. But I will say that that's usually pretty rare in the world, in the pediatric cardiology world right now. Usually we know pretty early on.
Another question was, what is the most common treatment for murmurs? So like surgical versus non-surgical interventions or things that you perform.
The most common procedure is me telling the parents that their kid's heart is totally fine. By far and away, murmurs are innocent until proven otherwise. Like I mentioned, murmurs tended to be more of something we leaned a lot more on prior to the advent of such good ultrasound techniques. When we didn't have the ability to prenatally diagnose things, it was a lot more laid upon. But I don't, a murmur, and I get this a lot of times, parents come in and they're like, well, this person had a murmur, this person had a murmur. If they did not have, see a cardiologist or need anything additional, every single human being in their lifetime, if we put stethoscopes on everybody and left them on there all the time, everybody would have a murmur at some point. So it doesn't mean it's it carries a diagnosis with it.
There were a couple questions actually asking how long it took you to differentiate between each heart sound, and if you have any advice to students to help learn how to distinguish between these sounds.
It took me like years. My biggest piece of advice is to listen to every single heart you can. When I was in residency and I realized I wanted to do cardiology fellowship, I did a heart exam all the time, every time, even on patients that came in for like nothing related to the heart. I always did a heart exam because, like I mentioned, the most important thing is to understand what's normal. If you don't know what's normal, then you won't know abnormal to pick it up. So I think that the best thing to do with this is to listen. And I'm not somebody who's very good at just like listening to these things. I need to have myself like feeling, touching, seeing, smelling the thing to be able to know, to understand it. And so any chance you get to listen to somebody's heart, listen to it and really discern what you're hearing when you have your stethoscope on the chest.
Thank you. That's good advice. Another question was, what are the key qualities and how do you deal with advocating for your patients?
Oh, that's a big one. I think that, how do I advocate for my patients? I think that a lot of what I try to do is really just, if you guys follow me online, you see I'm like all about empowering each other and physicians. I try to do the same thing for my patients. I really try to empower families and kids to understanding their bodies and understanding how they can, in kids who have heart defects or kids who have things, understand that something's not their fault and that they can have some power in certain things, and to be able to, ask specific questions and understand things fully by people who are taking care of them, and making sure that people never walk out of the office feeling like they need to Google something because they've asked all the questions, or if they do, they feel empowered to ask me what those questions are. And, especially in like my prevention, for the vast majority of patients I see is mostly about their hearts are healthy. And I always kind of insert in a little ways, especially with kids coming for a murmur or chest pain or something that's not related, I always spend a little bit of time talking to them about the fact that their heart is healthy now, but it's on them to take care of their heart for the future and empower them to know that they can do that by their actions and how they live their life.
There were several questions asking about stethoscope recommendations.
I don't know. I've always used, oh my gosh, why am I totally blanking on it? It's like the biggest one that you guys probably always get. Honestly, I'm totally blanking. I have a bunch of different stethoscopes.
Is it the Littman?
Littman. So yeah, I have a Littman. I think there's some pretty cool new stuff with there's like an Echo Health one where you can actually record heart sounds. I'm probably going to get one of those just so I be able to build up a bank of heart sounds and stuff. But honestly, anyone that you can hear something well and clear, I think is fine.
And then this will probably be the last question for today, but someone was asking, how does research intersect with your field, with pediatric cardiology, and what are some research opportunities that they could get involved with?
So there's a lot of research in pediatric cardiology, just like pretty much all fields in medicine. I think the most important thing if you're interested in pediatric cardiology is trying to go to more places that have really robust programs. So there's not a lot of children's hospitals have pediatric cardiology programs, but there are certain ones that have very high volume programs. So those are the ones, if you're going to be looking for a project, I would recommend, because there's just more ability to go across the spectrum with all the different kinds of areas of pediatric cardiology. But yes, dramatic, lots of research opportunities are available.
Great, thank you so much. I think we'll end it here for today. It's right around 2 o'clock, or our time at least.
Mm-hmm.
So thank you so much. If you guys want to go follow Dr. Rodriguez, she put up her handle and her email right there, or her website.
And my email is just reneeparo@gmail.com.